Hey, welcome everyone to our show. I'm really excited about the guest that we have on the panel today. I don't really like to use the word panel. I feel it's a little too formal. I like to kind of say this is akin to three nerds in a coffee shop talking about cybersecurity, nerding out on specifically ransomware in healthcare. So, with me on the show today is Mitch Parker, the Chief Information Security Officer for Indiana University Health. You'll hear us referring to as IUH. And he's been in cybersecurity for about 18 years. I'm going to have him introduce himself, as well as Kris Kistler, the Chief Information Security Officer for Cognizant Healthcare, who's been in cybersecurity for about 25 years. So, Mitch, you want to start out by introducing yourself to everyone?
Yes, thank you very much for having me, Alyssa. So my name's Mitch Parker. I've been in healthcare information security for about 18 years. I started off as a defense contractor, moved on to Temple Health, where I was CISO for 8 years. And then from there, I spent about a little bit over 4 years at Indiana University Health and focus a lot on building good defense, but also a good offense.
Awesome, Mitch. Thanks. Kris, welcome to the coffee shop.
Thank you for that. It's great being here, and it's a great pleasure to work with you again after so many years. Uh,
Yeah.
yeah, my background goes, I guess I've been in the field 25 years, and 10 years before that, I had 10 years in law enforcement, then got into computers, chasing bad guys there, uh, drew it down through both ISPs and healthcare specific hospitals, as well as now RCM solutions with Cognizant. The I guess driver for me is really the challenge, right? Is taking that challenge of trying to keep the bad guys out and going with it. Um, I like to refer it as not there's no such thing as perfect security and keeping everything out, preventing it. But what I like to base everything upon is how do we create a defensible network, right? One that we can quickly respond to threats, react to threats, and isolate threats. And that's defensible. And that's something that we can, all hope to achieve and drive towards.
Well, definitely. And, I know that today's topic is specifically because of your guys' role as a CISO in the healthcare space. But I don't want our audience to feel like obviously we're saying ransomware is just a major problem in healthcare. It's a major problem across all industries, of course. But specifically within healthcare, I mean, you guys heard about that patient who actually died because this was in Germany. She was rerouted to a different hospital because the hospital they were taking her to had been hit with ransomware. Now it's a religious debate, depending on who you ask, as far as whether or not that was the first death associated directly with a cybersecurity incident. But in my mind, had that hospital not been infected, she would have been admitted into the hospital scene, and even if she was in critical condition, had a much better chance, right? So I think the German authorities have come back now and tried to really downplay that incident and say, no, that wasn't directly attributed. She was in critical condition, but you still have, when you're in critical condition, time is everything, right? So in my opinion, I think that it was. But ransomware is a serious problem in healthcare because of the fact that you are dealing with life and safety, right? It's a lot different than a website getting defaced or an internal network being hit with ransomware. When you're talking about hospitals, when you're talking about connected medical devices, when you're talking about things that affect life and safety, I think it's a different game, right? You're talking about way different outcomes. Recently, we saw that UHS, Universal Health Services, was compromised. They announced a ransomware infection, I believe, in September. Of roughly 400 systems were infected. You know, caused phone, internet, data center, computer outages. Some sites had to divert ambulance services to different locations. There were delays in lab test results. I don't know if it's been confirmed yet, but Ryuk ransomware family was involved in this. I'd love to get your inputs on what's been happening. And we talked, there's this Texas-based legacy community health services that was hit. 228,000 patient records were leaked. AAA ambulance services in July was hit by Revel. 24 gigs of patient records were leaked in that. So this is a major problem. And I'm sure you guys saw my mHealth API and app hacking research, that video that went out. We're about to release the PDF report here soon in the next few weeks. One of the statistics in that was that patient health records per record now sell for 1,000 times more than a credit card number in the dark web. It's worth a lot of money. And I think crime syndicates know that. So I'd love to get your perspectives on this.
So first of all, I really do believe that the case in Germany was not the first case, simply because emergency rooms go on divert when there's a ransomware attack in the hospital. And I am well aware of multiple hospitals having to go on divert over the past 5 years because of ransomware attacks. Because like you said, time is everything. First time I saw a hospital go on divert for ransomware was about 5 years ago, and it was a small community hospital. So somebody sending a patient there, they had to reroute the ambulance to a hospital that was 25 minutes away.
Oh, wow. And do you know if that patient died? Were they in critical condition?
And that's the other wonderful thing about the United States. You don't find out a lot of this because, honestly, everything's under very tight NDA. So even if it did happen, because of our legal system, you would never find out.
Know. Right. And also, obviously the government wouldn't want, and we won't get in conspiracy theory talk, but I mean, obviously the government doesn't want to create hysteria or mass panic over ransomware leading to patient deaths, right? But I agree with you. I know I'm not naive enough to believe that we're going to be told everything, especially when it comes to something as elusive as cybersecurity breaches affecting the healthcare space.
And the deal is also, there's one other major factor that I've seen. My organization does a lot of root cause analysis of the attacks, even when they occur outside our organization. So when other organizations get hit, we find out what happened. And a lot of people in the security community talk, and we get a lot of good intel. And what I found is there's a lot of really legacy systems out there. Right. And there's a lot of open ports. There's a lot of open systems, and it makes it very easy to go in there and raise havoc. It's not just phishing emails. A lot of these attacks, they're planned out, they're methodical. They take months to execute, where they can literally be in the network, know where to detonate the ransomware, and turn it on. And we've seen this in multiple attacks. Yeah. And they do it undetected. And that's why these are succeeding. It's not because everyone's ridiculously insecure. It's because literally there's ways to get in, ways to be undetected, and ways to execute very quickly and make money.
Right. Yeah. Oh, it's all about, right. Because the days of 20 years ago, Kris, I know you go back this far, Mitch, same thing. Back in the old days where with World of Hell and Rafa and, the other defacement groups, it was all about defacing websites. Now it's about profit, right? So, we're facing a different type of adversary with a different modus operandi, different objectives. So, and it's all about data being worth more than oil, being able to profit from the exfiltration of data. And what's the problem here? I mean, to me, in my mind, I'm thinking employee hits a URL or file attachment or drive-by download site, whatever, and their workstation, whether it's a nursing station where a nurse is sitting at, or someone else in the administrative back office or whatever, gets popped with the drive-by download or dropper. The dropper grabs Ryuk or whatever the hell it's grabbing and downloads it, and you have infection. But to me, is a hacker, my first thought is flat network. How the hell are these hospitals having all this PHI and all of this data getting locked and leaked? If the network, if there was microsegmentation in place, if they're like, you guys can both, I know Kris, I know from the vendor side, Mitch from the healthcare side, is is it a flat network? Is that what we're dealing with here? Is it why are these workstations even able to communicate with systems transmitting, processing, and storing PHI?
It comes down to, in my experience, two factors. Number one is your excess permissions that a lot of these accounts have to be able to get a lot of software to run.
Local
Remember, a
admin.
lot of the software that runs in the healthcare space, it's old. It runs old Microsoft runtimes. If you remember, before Microsoft did everything with .NET, the old Visual Basic 6 runtimes, and that old software, that takes excess permissions to run. Plus, you have the combination of that and map drives where you have excess permissions where everyone
Right.
can read write on the map drives. Plus, also, you have legacy in there, which means you have servers that are running that are pre-2012, where you can very easily get in there. Once you're into a machine, you start pulling password hashes, and it's not that much effort to grab an admin password. And the next thing you know, you're off to the races on an entire internal network.
See, yeah, and I committed a cardinal sin. I tried to identify just one issue, right, of flat networks. But like in my experience over the last 20 years, it's multiple things, right? It's not just one part. It's patch management, lack of backups, flat networks, too much privilege for a user account, right? Local admin privileges. It's all of the above. Kris, what do you think? I mean, what's your perspective? And that's why I'm really excited about this conversation, right? I mean, we've got Kris from your side at Cognizant Health. We've got Mitch from your side at IUHS. So Kris, what's your perspective on this?
So, yeah, and I could go on about this for an hour if you let me rant, but what I see as a common thread amongst a lot of healthcare organizations in a lot of different perspectives, right? The biggest issue is lack of maturity and lack of funding, right? If we look back, right, there was the big Obamacare debacle, right, where that got forced out and it wasn't secure. A lot of media publicized about that. But this is a maturity thing. And a lot of these hospitals and healthcare networks and business partners are immature. They haven't grown into that level of maturity in their security space, so to speak, right? So they have a lot of legacy technical debt back from the old days when they didn't spend any money on security. And for the last 5 years is where they've been trying to play catch up. And a lot of them are still struggling to make that shift, right? It's not a simple lift and fold. Plus, we've seen a shift in the attack that has also matured, right? There's basically 4 main motivations for attack. One is the thrill seekers, right? The script kiddies just looking to see what they can break into, just trying to go after stuff. Number 2, we have the revenge seekers, right? Disgruntled employees or people just trying to attack out of anger, right? For whatever reason they feel slighted, so they want to go attack someone. Number 3 is political motivated. That's where we see the APT and other country attacks going after our political infrastructure and trying to disrupt our economy. And then level 4, which is actually the most dangerous, is the financial motivations. That's where we see organized crime come in. And we now have organized crime and organizations come in that are better funded than the systems that are trying to protect, right?
Yeah. So Mitch, do you agree with that? Do you think that's a lot of the root cause or issues?
I think there's a couple of things I'm going to add on to that as well, and that is healthcare as an industry has done a very poor job of educating its constituent members on what to do. I often spend a lot of time working with my peers at other health systems who don't know what to do. So to give you an example, FFIEC in finance does an excellent job of promulgating cybersecurity guidance through federal, state agencies, and also to the banks themselves. And FSISAC has done an incredible job. And also they've been aided by legislation, very specifically in New York and Massachusetts, that require banks to be members of FSISAC. So you've got, and FSISAC, I actually had a senior executive at one of the major banks tell me they fund FSISAC to make sure that smaller organizations benefit from it because it's the financial system. You mess with the financial system, people can't buy things. It's dangerous and really can shut us down worse than 2008. However, in healthcare, while we've seen some great work that's been done, specifically the work that Eric Decker's done, with Healthcare Sector Coordinating Council. We haven't seen anything like that for that sustained period of a time. Healthcare ISAC, while they do incredible work, they're nowhere near that. And the level of guidance and universal set of instructions you have for locking things down or having good cybersecurity guidance, it just isn't there yet. And I got to say, HSCC is really trying. However, organizations just aren't, it's really, Kris is right. It's a maturity problem. We don't know what to do. And
so if it's a maturity problem, are you guys saying that these organizations are simply just not, like these CISOs are just not sitting back and deciding on a framework choose like CIS-20 or NIST CSP and deciding on a framework and then doing a gap analysis of security controls? And is that it? Like, is it as simple as the CISO not sitting down deciding on a framework?
I'll jump in on that because it's in most cases, at least in the experiences I've seen, it's not the CISO's decision. Right? That CISOs really just started getting invited into the boardrooms a couple of years ago, right? I mean, these decisions are being made at the business level, and they have not, at least in most of the areas I've seen, have not taken that security area at the same level, right? They're more focused on business, on generating new business, on generating revenue, on moving the business forward, and tend to try to accept some of that risk, I guess, in many cases where they probably shouldn't, in many cases against the CISO's recommendations, right?
And I can jump in here a little bit too. What I've observed, and I've talked to a number of people, both on the vendor side and the provider side, they don't even know what to do. A lot of people that get these security roles, they did something else, then they literally got told, hey, guess what? You're doing security today. That's what happened to me. I mean, I had no guidance on what to do. So you go into a bank, you pretty much know everything you've got to do because it's written in triplicate and you've got everything done. FFIEC tells you everything you need. You don't have that for InfoSec. You have all sorts of things all over the map. And also a lot of the people who come into security think you could buy your way out of the security problems that you have. And I mean, I'm sorry, I talked to a number of my peers and I can't tell you, Kris, 90% of the time I talk to them, somebody mentions a product and how this product is helping them solve their problem.
Yeah.
And again, if the way I look at it is, if you can't tell the C-suite what the problem is, you're not buying a product to solve the problem. I would never dishonor my CFO that way. I like her very much, but I would never do that. And 90% of my peers, I think, they go, oh, we have this problem here, but we bought this.
Right.
And again, that doesn't work when you talk to the rest of the C-suite because they'll shred you in 30 seconds of my experience.
Right. You're throwing money at the problem. Right. So, there's this problem. And then Mitch, you brought up financial services quite a bit. Obviously, I have a bit of knowledge in this area as well. There was the announcement that went out where the financial services industry, financial services companies were pretty much spanked by regulatory about paying out ransoms. I don't know if healthcare organizations have received the same advisement that you could be fined for paying out ransoms. It's just perpetuating the problem because if they receive one big payout from this organization, they know that this particular industry is more apt to pay out ransoms if they're locked and leaked. So I don't know if healthcare kind of has gone through the same thing. But yeah, what's the issue here also? Is it, is fixing it high trust? Is it HIPAA? I'd love to talk about the compliance side of this as well.
So again, what I see a lot of it is healthcare pays. We've been told not to pay. We've been told repeatedly not to pay. However, the incentive is, and I'm going to quote Steve Long from Hancock Regional Hospital, who got attacked his hospital got attacked a few years ago. He said, I got to see patients. And he paid. And because there's also another incentive. If people pay, they know it's a working product. And it also gives the ransomers credibility. Now, I know Treasury is doing a lot of work lately with trying to tell the banks and trying to tell everyone in the Bitcoin exchanges, hey, guess what? You've actually got to follow and know your customer. You're a financial institution now, and they've made some arrests because of it. So there's a lot going on there. We've been told not to pay. Everyone's been told not to pay, but ultimately, to paraphrase Kris, the business ultimately is the one that makes the decision because they don't want to be down.
Yeah,
And
and it's in healthcare. I don't know about healthcare, but I know in financial services, it's OFAC that sort of levies those penalties. They were the ones who sent out the advisors saying you'll actually be in violation of these regulations and can get penalties for this. We can fine you for doing this. This was out with the U.S. Treasury. Who regulates this on the healthcare side? Who kind of spanks healthcare organizations and says, what are you doing paying out ransoms? You can't be doing this.
ironically, the same agencies, which is OFAC, that's
Oh,
under the Trading with the Enemy Act, and International Economic Protections Act, IEPA.
right.
Those are the two that get you. And
Okay.
also the Office for Civil Rights can get you as well for paying ransom.
Yeah.
And you have to do a full additional risk analysis on top. So healthcare actually has it worse because not only do you have OFAC, you've got OCR.
Oh, wow. Okay. So, I
Yeah,
mean, I know
HHS
you
and
guys,
OCR.
yeah, I know you and Kris have a lot of knowledge on high trust and HIPAA. Would love to find out what your thoughts are around that, and if you think it's doing any good. Like, we've had HIPAA for a while, 45 CFR, we've had high trust. Why is this still happening? If and I think it's been 15 years since I've read 45 CFR, but I mean, while they don't prescribe specific technologies you need to buy, specific security controls you need to buy, they do make recommendations on what you need to do with high trust and HIPAA. High tech? Why is this still happening in healthcare?
Yeah, so there's been a lot of change in that environment, right? If we go back early days, right? HIPAA came out back in I think late 90s, early 2000.
2000, yeah.
It never had any teeth, right?
Yeah.
They didn't enforce it. There were no penalties. There was nothing. There was really no teeth until about 5-6 years ago when they actually, kind of reinvented the HIPAA Omnibus Act and added some new controls, got a little more specific. They added the High Tech Act, which requires more logging and accountability in place. And then they started actually imposing some $2-3 million fines. And that started getting people's attention. And that was really the turning point when a lot of healthcare really stood up and said, oh my gosh, I guess we do need to fix our stuff, right? And it wasn't that many years ago, less than a decade ago, right? Before they even started getting serious about it. So then we had other things come in, high trust, HIPAA, just on a note, right, is very general. The requirements are very loose, very generalized. They're non-specific.
Right. It doesn't say like you have to buy this, you have to buy that. It's
very generic
general.
rules. You can pretty much make up whatever you want to meet the guidelines, right?
Yeah.
And yeah, it's not effective. So what most companies did in other industries, like the ISP industry and other industries, they used other international frameworks like ISO 27001. Back in the early days, it was BS 7799, but then ISO 27001, 27002 is now out. And that was a more structured formal framework. Then NIST started coming out, right, with NIST 883 and other NIST standards to define this. High Trust came out back in, I guess, also mid 2000s, 2005, 2003, something like that. And initially, I used to be a big ISO guy because Savas, we did ISO all over because we were multinational. We looked at High Trust there when I was at Centura Health, and I fell in love with it. Number one, because it was based on ISO standard, right? So it was very similar to that model as an organizational framework, but it was a little bit more specific to healthcare. But the main reason I liked it is it was more specific. It actually defined things. It said, well, not only do you need to manage your user accounts appropriately, right? Where HIPAA just says, oh, well, you have to manage your user accounts. Well, what does that mean? Right? Where the High Trust says, well, you have to manage your user accounts. You have to have a process to document when access is granted. You have to have a process to terminate those accounts in 24 hours when appropriate. You actually have to review the access that is appropriate every 90 days, right?
Yeah.
So actually it has more valid real world security controls that actually have some security value behind them. Compared to other controls, I think HITRUST is probably 75% or more of good, valid security controls, right? Instead of just make believe, because compliance, let's face it, compliance is not security.
Right.
And very often you get wrapped up in doing the compliance checkbox, and then security, the real security initiatives get ignored.
I passed my audit. I'm good. I got my certification. My attestation.
Yeah, so, and what we need to focus is both. And HITRUST is great because it combines more than 30 of those regulatory standards into one normalized framework. So you have now, because healthcare isn't just about HIPAA, right? We have to look at CMS regulations. We have to look at ENAC regulations, the HIPAA, the high tech, all of these various regulations come into PCI if you're processing credit cards, right? All of these things come into play. Well, HITRUST organizes all those into one single framework that you can audit once and then report many. So that's why I'm a huge fan of it. Not so much the certification, because again, that gets to be too much busy work, right? But as far as an organizational framework for a company to use to structure their processes, policies around, fantastic.
What about you?
Absolutely. We're big fans of HITRUST, and we strongly encourage our vendors to use it because it makes our job a lot easier. Because again, with us, what we've done is we've taken HITRUST and we bolstered it with, you need to stay current on HITRUST. You can't just get a certificate and say you're conformant with this version of the common security framework and be good. No, we require you to keep it current. And we do that because, again, we tell our vendors, ultimately, it's more economical for you to be HITRUST compliant than it is for you to pay an analyst to fill out questionnaires for every single solitary vendor. You do one HITRUST certification, ultimately, you've got good security processes in place if you maintain it, and the resources, you will actually save money by only having to do it once. And that analyst that you have filling out questionnaires for people can be used to leverage and do real security in your organization, making sure you do a better job. We love HITRUST because of that. And in the payer space, because we've also got a health plan, that's actually pretty much de rigueur because the Blues enforced HITRUST with their vendors. So we got a HITRUST. We tell vendors, you come in with HITRUST, it's a half hour to go through our vendor process because we trust HITRUST because of the process it makes you go through and the organizational maturity it makes you achieve.
It's automatic de facto trust. You just trust that organization. They're maintaining their compliance with it. So what about the location of the PII and PHI data in a healthcare environment? Where is that just traditionally stored? I mean, for me, I would imagine there's a lot of months of living off the land and lateral movement within the organization once they have a beachhead on the network in order to find that PHI. But it seems like, I don't know, maybe it's found a lot more quickly than that. Is this a problem? Like, doesn't HITRUST require that PHI or regulated data be stored in a micro-segmented, isolated environment that is not accessible to these machines getting hit with ransomware? Why are they even able to access PHI so quickly and lock and leak it? It had micro-segmentation or zero trust networking, all that stuff been in place, it wouldn't have been an issue, right? I mean, where is this stuff being stored?
Well, and that's a great question, but the answer is, right, it's more complicated than that. It's just actually not that technically easy to do that segmentation. There's two areas of data. There's structured data and unstructured data. Structured data is what most people think that all their healthcare data is in, right? Oh, it's all maintained in this nice structured database that's all contained.
It's an MS SQL database.
It's on this one box right there, yeah. But and we would all, I think all healthcare would love to get to that as the ultimate goal. But the reality is, with all of the interactions that are required to process that data, right? You have to go to the insurance company to see if it's valid. You have to go to the payer to get paid. You have to go to this part to see, well, you know, does it go to x-rays to get x-rays? Does it go to this group to get other testing done? There's all this data and information has to flow back and forth, not only within that healthcare entity, but between healthcare entities, right? That often have mismatched systems because they're still technically immature, right? They just got off paper, what, a decade ago, right? So that's a very struggling part. So while the majority of that information may be in a nice structured database that's clean and contained, the rest of it has to go through all these other areas, which means there's typically some floating around in email systems. There's typically some floating around in Excel
PDF files
spreadsheets or Word
around.
files, right? Yeah, exactly. What about faxes, right? We're still using faxes that come in
There's
and go
still fax
back.
machines in healthcare. Oh my gosh.
Oh yeah.
Yes, there are.
Yeah, and not even digital faxes. I mean, the
Not
actual
e-fax or something like that. E-fax
Yeah.
don't exist anymore. But yeah, I would think in addition to the structured databases, there's PDF files just sprinkled everywhere on shared drives, shared folders. It's just everywhere. Mitch, what's your input on this, on the storage and location of PHI?
Well, the deal is that when you have a lot of literally most healthcare workflows look like Rube Goldberg machines. When you take a look at them, that's about the best analog I can give you. You take a look at how revenue cycle operates in most health systems. You're talking about years upon years of processes with significant manual intervention. This is the reason why robotic process automation is so big in healthcare now. It's because you still have these manual processes you just can't get rid of. And you want to be able to speed it up, and you can't throw people at it.
So it's not as simple as like creating this sort of micro DMZ or inside the internal network and just put the database server there and only these ports and protocols are allowed to do it. It's not as simple as creating this enclave for, you're saying there's digital transformation involved of old archaic networks and systems sitting around, data sitting around everywhere. No one knows the applications, protocols, ports, numbers, all those things that are being used. It's a much bigger problem than simply just saying, okay, these VLANs and these VACLs are going to fix this.
Absolutely, because what ends up happening is to make these ancient applications work. And again, this is a generic healthcare problem. Healthcare revenue cycle is a mess in most companies. That's why there are robotic process automation companies with $1.5 billion valuations. It's because they're automating ancient processes to try and figure out what they're doing to be able to put them forward. But unfortunately, you have core applications that are out there that are so old, and because you have to interchange information in unstructured formats because there's simply no way to interchange, and ultimately it gets down to the fact that you don't have ultimate ways of sharing information about people because there's no universal identifier between organizations. So if I see patient X, they got one ID here, patient Y, one ID over there. You have to do a lot of manual piecework to reconcile people. And this entire process makes it incredibly difficult. Where on the care delivery side, you can put a workstation out that doesn't have PHI in it because everything's stored in your EMR. Your workflow can actually be pretty tight with anything involved in the care process because everything's located in these centrally managed monolithic applications. However, once you start getting into the area where a lot of the old processes and digital transformation has been slow, that's where you start seeing the real mess. And that's where you see PDFs all over the place, access databases, Excel. It's because literally these people don't have the tools to do their job. And you have PHI all over the place because of it.
Wow.
And you mentioned a key word there was digital transformation, right? That's a huge phrase in the healthcare space right now, right? Every healthcare entity I know of is going through a huge digital transformation effort, right? And part of the challenge here is that a lot of them don't have the funding to implement it with all of the proper business continuity things in place, right? Because think of that, it costs so much money to do a digital transformation. Well, it typically costs double that money or even more to now have an effective business continuity solution, right?
Right.
To ensure there's no downtime. And most of the ones I know of right now, they may have that partially in place, but at least in the provider space, right? So not necessarily where I currently work, but in the actual provider space that's providing services, as Mitch mentioned earlier, that doctor says, or that physician says, well, hey, we've got to see patients, right? That hospital has to see patients. And most of them are still relying on a paper backup solution, right?
So
Because of that funding. So they have to have a process that works both digitally and be able to instantly revert to a paper process in an emergency.
So kill chain, adversary establishes the beachhead, dropper establishes the beachhead, downloads the ransomware, lateral movement, pivoting, collecting, dumping credentials from memory, Kerberoasting, grabbing Kerberos tickets, golden tickets, just carving everything out of memory, grabbing credentials, moving around via RDP, whatever. Isn't the solution to this problem just implementing MFA? Isn't it just implementing like just sell them Okta or sell them, and any one of the number of solutions and turn it on an Active Directory and the problem solved? Like what is it? What do you guys think?
Well, each one of those vendors would love us to believe that, right?
I was going to say, these vendors have never heard of BGP hijacking or DNS hijacking or using transparent proxies and just sniffing the MFA as it goes across the wire. We know how to do that.
Yeah.
And
it's
back to
never a silver
MFA
bullet.
single sign-on, right? I mean, everybody would love single sign-on, right? Even HIPAA, even the ancient HIPAA recommends single sign-on, right? And it's a great idea if that single sign-on is secure. The problem is there's varying levels of that security around single sign-on capability, right? And if you break it, well now, and you have single sign-on, you have the keys to the kingdom, right? You can move all over the place. So that's why it's important to use layered security and strong encryption and stronger authentication in those areas. One, so that, the encryption so that the credentials can't be sniffed off the network wire, right? Man-in-the-middle attacks are still very much in play and in use on different networks. And then having that multi-factor authentication, although we need to be clear that there's also different levels of security around multi-factor authentication, right? They're not all built equal. Even NIST, right, calls that out in their requirements, right, where they don't want you using a voice over IP phone for that multi-factor authentication. It needed to be a dedicated number. And again, doing a push methodology instead of just a SMS callback, right, which could be intercepted. So, many layers and of differences in there. And, I'm a huge fan of the good layers of multi-factor. There's, again, every vendor wants you to think they're the best, but, a company that's looking to deploy that should look at not just the multi-factor capability itself, right? We need to look at, well, what is the ease of use for the users? Because they all want to bypass it and complain if it's not easy to use, right? So
eliminating user friction.
They provide multiple methods, and then even being able to split out the different methods per application. So you can put the higher levels of multi-factor authentication on your higher value applications, right? And the lower ones on the lower value.
I offer, obviously offer that, silver bullet and as an idea in jest, but I mean, what about XPE, PC over IP, VDIs, virtual desktops? Is that also a solution for healthcare companies to simply just move to that? I've always been a big believer in the elimination of the castle and moat idea of hardening, right? Where data's everywhere now, the castle's left the moat, security should be in layers, right? One of the layers should be virtual desktops. What do you think, Mitch?
Absolutely. I mean, that started off in the insurance industry about 15 years ago, but we love it because you can turn off that clipboard, you can turn off the ability to transfer files, and it gives you a window. Obviously, you're not going to stop screenshots because you're not going to stop someone with a smartphone, However, it gives you a near zero footprint on someone's device where they don't store anything. What you have to be worried about is you can't just put it on there and say you're secure. You've still got to configure that VDI environment to literally have as little access as possible, not have file shares on it, have only the apps they need, and rebuild itself completely after use. So all of which a good VDI environment has. So again, it's like a desktop. It has to be maintained like a desktop, and you've still got to have a lot of good security there. It just makes it a lot easier to do. And honestly, it helps a lot with latency because these big complex applications, you're not supporting them over a VPN connection where they'll suck. You're supporting them in the data center where they don't.
Right.
So we like VDIs, but you still got to be very secure in how you configure them, and you've got to keep them up to date. Because again, they use encryption protocols, PCOIP or ICA. They have vulnerabilities too.
Right. Citrix
You've
just
got to
got
keep them patched.
that major remote code execution. There's going to be vulnerabilities in anything, and it needs to be properly hardened, especially something like a VDI.
Yeah, I'm a huge fan of VDI technology. And this is going to belie my age a little bit. I actually co-authored the book back in 1999
Oh, wow.
during Citrix Metaframe on Windows 2000.
Metaframe.
Right? This is not something brand new. This technology it goes back a ways, right?
Yeah, yeah.
But one of the best benefits of using that technology, if it's properly configured to restrict the file transfer, as Mitch said, restrict the file transfer, restrict screenshot capability. If you do that, the biggest benefit is you're no longer transmitting actual data, right? As far as information,
you're eliminating
you're basically transmitting a screen capture, right, and a video feed, so that data is not sitting at rest on that remote endpoint. You're keeping all of your important information then centralized in the data center where you want it to be, right? To your earlier point, well, can't we just put it all in one database, right? Well, yeah, technically we could, but not yet.
Yeah,
right?
We'll get there.
We're not at that level of maturity yet, technically to be able to do it, but it's getting closer.
Yeah, and for our audience who doesn't know what VDI is, I'm assuming virtual desktop interface is what the I stands for, is interface. But for our audience who doesn't know what virtual desktops are, keep me honest here, guys. It's a system. It's like a thin client. Doesn't run the full operating system. It's simply just a viewer to a central system that presents you your own unique interface to that system. So if it were to get popped because you went to a drive-by download site or clicked on something you shouldn't have, that malware is not really going anywhere. It's not going to infect the system as if it were running Windows XP or Windows, Windows 10. That might be exploitable if they were.
Yeah, it keeps you in your own little world, and it also gives you the option of not running Windows on the endpoints that access the VDI, which is even better. You can use a really locked down Linux client to access VDI. Or in my case, I've got a Raspberry Pi sitting next to me that I use for VDI.
Yeah, love Raspberry Pis. Yeah, exactly. Yeah.
And back to the point on that I like to go to as well, right? Because security isn't just about keeping the bad guys out, right? Real security is also about enabling the business, right? So that remote desktop and VDI capability, it's helping enable the business. It's more cost effective than supporting a bunch of remote laptops, right? It's more appealing to the user because they can access via different devices, right? So this is one of the areas where security can help enable that business and help drive that technology for the users.
Exactly. And well, obviously, let's all point the pink elephant out in the room. What our discussion today really is a narrative around zero trust, right? Not trusting the user just because they're an employee, not trusting now their home networks because of the pandemic and working from home, not trusting the network infrastructure, even if it's the intranet. And I know we could do a whole show on zero trust, but it really is, we're talking about ZT here. We're talking about really not trusting how would you describe it, applications, people, and infrastructure. It's not trusting any of it. Validating, basically authenticating and authorizing everything, whether it's legitimate nurse user ID or doctor user ID, or something else. It's just because it's a legit account doesn't necessarily mean they're authorized to request that data.
Yeah, I mean, back to that, and I like to think of zero trust more because a lot of people hear that, and like psychologically we go to, oh, well, we don't trust the user. Well, I don't know we ever did trust the users or the admins or anybody else.
But we shouldn't have.
Yeah. But the real concept is not trusting one system to another, right? That's the real core concept there that I think we need to get around. If you go back way to the early days of computers and hacking, right? The Morris worm got in how? Via a trusted system and a trusted network, right? So yeah, this is like going back to square one of security, right? Back to the very, very basics of not trusting those systems to just talk to one another, right? Putting those gates and I don't like to call them, roadblocks in place, but putting those filters and speed bumps in place, right? To examine that traffic and identify that traffic that's going through and making sure that it's verified and valid. So.
Yeah. And, I know we're getting to the end of our show here, but, I do want to make one, because this whole conversation is bringing me to the discussion about APIs, especially in healthcare. And, as you guys know, my crunk juice, as my wife would say, is hacking APIs. And I'm doing this research around hacking mHealth APIs, especially with so many people visiting their physicians, clinicians, mental health providers over mobile health apps. I know, Kris, your company does a lot in the mobile healthcare space, and I guess telemedicine. You got mobile health, you got telemedicine, you got all of this stuff now is digital. Even visiting your doctor. Mitch, I know you've probably got an API attack surface going on. Is this what keeps you and Kris up at night? Is your APIs? What as we close out here, and if we talk about your predictions for 2021 in healthcare and cybersecurity, is it APIs? Is that with moving away from monolithic applications to microservices? Mitch, you talked about that. Is that what we're talking about here?
Absolutely, yes, it is, Alyssa, and I'll tell you why. Because organizations are pretty much on a death march to implement the terms and conditions of the 21st Century Cures Act, one of which is FHIR 4.0.1 compliant.
FHIR, yes. Actually, I'm working with a client right now that's having me pen test their FHIR implementation. I'd never heard of FHIR before this. And I guess it's very similar to the FDX. Mitch, I know you have a lot of financial experience. The FDX API specification. I think FHIR is very similar to this, but on the healthcare side.
Yeah, it's very similar. It's all XML and JSON, but the whole thing is there's a lot of people that put APIs out there, and the regulations themselves, the Cures Act, does not specify how to secure them.
Yeah.
It says you got to be secure. It doesn't say how. And I've had discussions up and down healthcare. There's some companies I'm not going to name who I've talked to that are on the ball, like you wouldn't believe it. And I'd say some of the larger EMR companies do a great job with their APIs, but everyone else, if I ask them if they've even heard of doing source code analysis, they look at me like I got three eyes. And where I see a big problem is FHIR 401 with OAuth 2 enabled APIs and good identity management. Putting that all together, there's going to be a lot of very rickety implementations at first that aren't from the big EMRs. And that's where I think the big attack surface is. If your hospital or health system doesn't run current on one of the big ones and follows all their guidance, you have a huge attack surface. And that's where I see the big challenge being in 2021 is people putting up these APIs because they feel they have to, and putting something up that is going to get hacked very easily.
Is that what keeps Mitch up at night right now? And especially as we enter 2021, is your APIs?
APIs are one of the many things keeping me up at night. And I can tell you, being in this business in my role for the past 12 years, I don't rest easy. And I never have in this position because there's so much out there. and it constantly changes. And APIs are, that's the next frontier. I mean, where you're going to see some pretty big hacks, I think, in the next couple of years.
Yeah, I agree. I just finished looking at, and hacking 30 of them, and it's you probably wouldn't be surprised what I found. So it's just that I don't think either you or Kris would be shocked anymore after doing it this long. But yeah, there are some API implementations, like you said, Mitch, some that aren't even implementing tokens. There's just no token. They're doing basic authenticate. I'm still seeing basic auth in 2021. What's happening?
Yeah, my head about it exploded when I heard the fire come out, right? And not only it came out several years ago, and this was at a previous company, and I'm like, oh my God, we're not rolling that out. And I put the nix on it. So there's no way that's mature enough. There's no way our code was good enough at that time. And then what happens, right? The next thing that happens is CMS, right? Centers for Medicaid, Medicare come out and say, well, you're going to implement FHIR by this date, or you're going to start paying penalties and fines.
You're kidding
right?
me.
And that goes into effect this year.
A forced migration to FHIR?
That goes into effect this year. Well, not necessarily FHIR, but to that availability, right? We have to
API it. So
accessibility. We have to make those records accessible to the patients via their mobile devices.
Wait. So you're telling me that the same thing, you're telling me that the same thing happening in the UK with open banking is happening here in the United States with healthcare?
Yeah.
Oh,
yeah. Go look at it. It's spooky.
I had no idea this was going on. I had no idea.
Yeah. And I'm like, there's no way we can expose this. We've got to have, again, the starting gate for any internet-facing application needs to be multi-factor authentication, right? That needs to be the get-go. And I haven't even seen that supported for most of those FHIR apps or API apps. Some of them are now offering, which is better than no MFA. There's, some great companies out there now offering two-stage authentication, right? Where it goes to another API key and it does a second level of authentication. Huge benefit. Huge.
Yeah. Well,
right?
it's funny because some of the apps that I've looked at in my research are just using the API keys that are hard coded in the app for authentication. It's shocking. Yeah.
Again, they're not following basic security practices because they're not mature enough and don't have the funding to implement all those things at once. They're in a race to get it out the door.
Yeah.
Right?
It's shocking. I think we need to do an entire show just on API security in healthcare. This is a really sexy topic to me, and I could nerd out on it all night long. And I would love to have you guys back for that. But Kris, what's your 2021 predictions in healthcare cybersecurity?
Well, caught me off guard. My predictions are going to be, yes, you're going to see more API hacks. Yes, you're going to see more ransomware attacks. You're also going to see a lot of, I think, legislation around that ransomware, right? Like Mitch said, around you're going to get penalized if you pay it. And that's going to help curb some of that. But you'll still see some of that happening on the black market, right? It'll happen on the side. And what will happen is companies will pay it. They just won't call the FBI anymore, right?
Right.
Because they don't want to get in trouble now. So, there's going to be a trade-off there. You're still going to see a big attack in web attacks. What we're seeing is a shift, and if you guys haven't noticed it, and I think we're going to see more of this, is we're seeing a big shift instead of hacking from the outside in, right? Like, you find a hole in the firewall or you find a vulnerability and you hack your way in. We're finding more and more hacking from the inside out. And that's via a phishing attack or via compromising an employee and getting some other type of internal credentials or doing some other social engineering attack and getting those credentials and then hacking your way out from in, right? And exfiltrating data via a normally okay method. So those are things that we're going to need to watch out for.
And absolutely, Kris, I will tell you, I took a look at an attack like that happened to another institution. I have actually seen evidence of what you were speaking of.
Oh, wow. Yeah, I think it's going to be a very common theme in 2021. I think just from what I'm seeing also, on the adversarial side, I think more and more hackers, whether you're talking about RAS as a service operators and affiliates to nation state, I think they're learning very quickly learning how to exploit APIs, trying
Yeah.
to learn how to exfiltrate data from them, because it is just because you're a pen tester, just because you can compromise an IIS web server doesn't mean you know how to hack an API. But I think they're learning, and they're learning very quickly, and we're seeing that in the prevalence and increase in the number of API breaches, especially with countries like the UK and open banking, and the United States now with healthcare. With this forced regulatory requirement to move to APIs to make that data available. And God help us.
Yeah. Oh, yeah. Well, and on that note,
Oh my God.
you're going to see the APT and foreign country attacks, right? Quadruple, if not increase tenfold. Right?
Yeah.
All the political unrest and all the disruption in the world right now, those attacks are going to just grow exponentially.
Yeah, I agree. This has been an exciting conversation. You guys are dear friends of mine. I love you guys to death, and I really appreciate you guys being on the show with me to talk about this. I think this needs to be explored more, and I would love to definitely drill more into this, especially on the API security side with you guys in healthcare, just because, as you both know, it's my Kool-Aid. I love talking about this, and I think it needs to be talked about. I think we need to talk about fire more, and we need to talk about these other issues and challenges more, especially from the CISO's perspective. I think your guys' perspective and input is very valuable and helps other CISOs in healthcare kind of understand what they need to be thinking about and what they're facing. So thank you very much for being on the show today.
Hey, this was
Thank
great.
you.
I'm looking forward to that report coming out.
Oh, it's going to be a doozy.
Yeah, I know it is. And thank you.
We've retained a
Some people don't like that kind of thing, but my gosh, I'm a big fan of full disclosure as well. There was a big controversy that year ago, right? But that's how we improve our systems and make them secure, right? Is by researching and testing and identifying all those sore spots before the bad guys do, and then fixing them. So, the service you provide is fantastic.
Oh, thank you, Kris. Yeah, I really enjoy my research. You guys have both been, my biggest fans and followed my content for a while now, and I really appreciate your guys' support as followers and helping to put my content out there. So I'm excited to put it out too. We've retained a PR firm. We just think this is going to be huge, especially with the pandemic and work from home. So thank you to you and Mitch.
Thank you.
Thank you.
All right. Thanks, guys.